Okay, hi everybody. So this is just a quicker version of my other presentation. So today we're going to be looking at a psychopharmacology review, or maybe reviewing some guidelines, and talking a little bit about cytochrome P450 enzyme metabolism. We do this for illustrative cases, there'll be lots of mnemonics moving forward. Alright, so these are the objectives for the presentation. As a disclaimer, this is a fairly rudimentary review of medications from these guidelines. We're not going to be discussing dosing strategies or side effects. And as a personal disclaimer, I would just say that some of the cases involve humor, but mental health is no laughing matter. So we'll begin by talking about the first-line pharmacotherapy for several anxiety disorders. So we'll be talking about generalized anxiety disorder, OCD, panic disorder, PTSD, and social anxiety disorder. So this case reads, Dave is a 28-year-old male college student with no previous connection to psychiatry. He reports struggling with always feeling worried. It has been a lifelong struggle, but worsened in his teenage years as he transitioned from high school to university. He reports feeling breathless and tense, particularly when stressed with final exams, and experiences initial insomnia more days than not due to not being able to shut my mind off. Concentration has been an ongoing concern as well, and he tells you that it's been particularly difficult to put together a PowerPoint for his classmates. ADHD skills do not support that diagnosis. So this diagnosis is generalized anxiety disorder, and the first-line pharmacotherapy is duloxetine, agomelatine, venlafaxine, escitalopram, sertraline, pregabalin, paroxetine, and paroxetine CR. The mnemonic to remember these medications is Dave's PowerPoint. On to case 2. So Anne is a 48-year-old orofacial surgeon transferred to your office after her longtime psychiatrist relocated to another province. Her history is significant for OCD and OCPD tendencies, which were diagnosed when she was 21. At that time, clomipramine and CBT were effective in reducing obsessive/intrusive homicidal thoughts related to killing strangers. Once those distressing symptoms remitted, pharmacotherapy was discontinued. Obsessive-compulsive traits have persisted, and Anne has come to see them as an asset in her personal life. Most notably, she is a self-described perfectionist, prefers that her workspace be kept effing spotless. During her appointment today, Anne breaks down after sharing that her husband of 20 years passed away in a helicopter crash 2 months ago. Since this tragedy, she has experienced recurrent intrusive dystonic thoughts of murdering her patients during procedures. These thoughts have been so intense that she has taken a leave of absence due to the fear that she will not be able to prevent herself from her murdering a patient. What are the first-line medication options for OCD? They are escitalopram, fluoxetine, fluvoxamine, sertraline, and paroxetine. As a bonus question, what makes clomipramine so helpful in OCD? It's thought to be the serotonergic activity of this TCA. It is the most serotonergic TCA of the 3 common TCAs we use. So those medications again are escitalopram, fluoxetine, fluvoxamine, sertraline, paroxetine. The mnemonic is effing spotless. Okay, so on to case 3. For PGY1 working in the emergency department, you've been asked to see Victoria, a 23-year-old college student with a chief concern of chest pain. She has a normal BMI and no risk factors for cardiac disease. She tells you that she was participating in an escape room when out of nowhere she felt a surge of anxiety that was accompanied by chest pain, sweating, nausea, and an inexplicable fear of dying. Although she now reports feeling fine, these symptoms caused her friends to panic and demand that she go to the ED to get checked out. She expresses fear about having another episode, as both scary and embarrassing. What if it happens in school? After completing an admirable cardiorespiratory exam and ruling out nefarious causes of chest pain, you wait patiently for your attending to review. To assist with recall, you have to clumsily type Victoria, escape room, cause for friends to panic. What is the most likely diagnosis? So this is a panic attack and may suggest panic disorder. First-line medications for panic disorder include venlafaxine, escitalopram, sertraline, citalopram, fluoxetine, fluvoxamine, and paroxetine. So once again, venlafaxine, escitalopram, sertraline, citalopram, fluoxetine, fluvoxamine, paroxetine, and paroxetine continuous release. The mnemonic is VESC-F2P. Okay, so on to case 4. Vesper is a 13-year-old female referred to your office for assessment of extreme shyness. She is reticent and difficult to engage in history-taking. Thankfully, her foster mother has attended with her and is able to provide collateral history. Vesper has been in foster care for 6 years. Both of her biological parents suffer from substance use disorders and would often leave her at home under the care of her grandmother, who is extremely controlling, and who would use humiliation as punishment. We're told that she has always been shy, but after moving to a new school 6 months ago, she has expressed concerns about being humiliated or embarrassed in front of others. That is, Vesper fears pure child reactions. As a result of these fears, she's been missing school. She blushes as her caregiver shares these details with you. Most likely diagnosis, social anxiety disorder. First-line treatments include venlafaxine, escitalopram, sertraline, pregabalin, fluvoxamine and fluvoxamine CR, and paroxetine continuous release. So once again, those medications are venlafaxine, escitalopram, sertraline, pregabalin, fluvoxamine and fluvoxamine CR, and paroxetine continuous release. The mnemonic is VES-FPCR. And just to highlight the differences between social anxiety disorder and panic disorder first-line medications, I've included a section on the slide here to detail that. Okay, on to case 5. So your primary care physician about to see Mike, a 58-year-old officer at Saskatoon Police Service, for the chief concern of insomnia. You've been working with him for the past 24 years, although you've not seen him in clinic in the past 8 months. At your last meeting, with the exception of seasonal allergies, he was in peak physical and emotional health. He's not on any prescription medications. You're surprised to find Mike a shell of his former self. He's slouched over on the examination table, unshaven and wearing a wrinkled police uniform. There's an unlit cigarette butt hanging from his mouth and an extra-large Tim Hortons coffee in his hand. From the dark circles around his eyes, you can tell he has been sleeping poorly. You sensitively engage him in conversation and learn that he responded to a call about a suspicious man entering a local residence through a basement window 4 months ago. Whilst investigating the scene, Mike entered the basement and was surprised to find the suspect violent. The man charged at him from across the room with an edged weapon. Instinctively, Mike drew and discharged his firearm. The man was killed instantly. In the months since, Mike has experienced recurrent nightmares and intrusive daytime symptoms related to the event. He's become despondent, depressed, and unable to focus on his work. He's been unable to drive down the street where the event took place and has forgotten to hook up his firearm on a number of occasions since that time. Although well known as a man with a gentle demeanor, he shared that lately he has been snapping at his wife and kids with little provocation. What is the most likely diagnosis? This is PTSD. And what are the first-line medications? These are paroxetine, fluoxetine, sertraline, and venlafaxine. So once again, they are paroxetine, fluoxetine, sertraline, and venlafaxine. The mnemonic is police find suspect violent. This slide is a summary of the first part. We have generalized anxiety disorder, which is duloxetine, agomelatine, venlafaxine, escitalopram, sertraline, pregabalin, and paroxetine continuous release. For OCD, we have escitalopram, fluoxetine, fluvoxamine, sertraline, and paroxetine, and effing spotless. For panic disorder, we have venlafaxine, escitalopram, sertraline, escitalopram, fluoxetine, fluvoxamine, and paroxetine continuous release. For social anxiety disorder, we have venlafaxine, escitalopram, sertraline, pregabalin, fluvoxamine CR, and paroxetine continuous release. And for PTSD, we have paroxetine, fluoxetine, sertraline, and venlafaxine. So now on to adjunct medications for anxiety and related disorders. So if you believe me, this is a fellow in a parka. His face has REO as the eyes and mouth, and he is saying barp, which is a representation of burping. Okay, so back to Dave's generalized anxiety. Dave is receptive to your first-line treatment for generalized anxiety disorder and eventually reaches the maximum dose for this treatment. On follow-up today, he thanks you for your help so far, but feels that despite some improvement in symptoms of GAD, he continues to experience clinical distress. You discuss the options of switching medication, offering psychotherapy, and adding an adjunctive medication, in addition to recommending lifestyle modification. Because he has had some improvement with his current treatment, you decide to go ahead with an adjunct medication. Dave has more PowerPoints coming up this year. So what adjunctive medication has the highest evidence for efficacy in generalized anxiety disorder? There's only one medication, it's pregabalin. Okay, so back to Anne. Anne is responsive to your first-line pharmacotherapy for OCD, and her symptoms gradually improve over the course of 2 years. She was able to return to work and has started dating again. She continues to miss her deceased partner, but has been generally content with life and continues to keep things effing spotless. In follow-up, Anne tells you that she was recently asked to take on the role of program director for the orofacial subspecialty program. Symptoms of OCD have not returned, but she's concerned that they might as her stress load increases. She asks you, what can we do in the event the first-line options aren't enough? That is, what are the first-line options for adjunctive medications in OCD? There are 2 of them. These are aripiprazole and risperidone. Okay, so now back to panic disorder. You're a PGY5 resident working in parallel with Dr. C in the Rapid Assessment Clinic. Your next patient is Victoria, a 23-year-old college student, referred to the emergency department 1 month ago with query panic disorder. Today you're joined by Mira, a very caring medical student who's interested in family medicine. Preparing to meet Victoria, you begin quizzing Mira on the various treatments for panic disorder. As she exhibits her keenness, you start wondering if Mira could be convinced to apply to psychiatry instead of family med. Daydreaming about a future where all physicians are capable of providing competent care for patients with mental disorders, Mira's interrogative tone brings you back to reality. She asks, what med could we use if Victoria is only partially responsive to the first-line option prescribed in the ED? How do you respond? There are two medications. There are clonazepam and alprazolam. Alright, now back to Mike and PTSD. It is the one-year anniversary of the night Officer Mike was involved in a fatal shooting of an armed suspect whilst investigating break-and-enter. He's been perfectly adherent to the first-line treatment you prescribed and has been attending trauma-focused therapy for the past 2 months. Mike attends your office, casually but neatly dressed and clean-shaven. His affect is notably brighter, but the dark circles around his eyes are unchanged. Daytime symptoms seem to have improved, but hypervigilance and nightmares persist despite reaching maximum therapeutic dose of his first-line treatment. Mike reports nightmares occurring 3 to 4 times per night, 4 to 5 times per week. He's not been able to connect with a psychiatrist despite referral 1 year ago. What are the adjunctive medications recommended for PTSD? They are risperidone, ezopiclone, and olanzapine. As a bonus question, what medication is commonly prescribed for nightmares and PTSD? It's prazosin. Alright, back to Vesper and social anxiety disorder. Vesper, now a 22-year-old scientist with a master's degree in bioengineering, attends your office with her partner Dylan. Although there has been much improvement in symptoms of social anxiety disorder, she still finds difficulties making small talk and blushes easily. After failing trials of sertraline and escitalopram, she found success with venlafaxine, which she has been taking every day for several years. She tells you that she made the appointment in order to discontinue venlafaxine. You see, she recently connected with her biological sister and learned that both of her parents and several siblings have been diagnosed with bipolar disorder. Dylan, a pharmacist, expresses concern about Vesper continuing to take venlafaxine given her genetic risk factors. Collaboratively, you decide to switch to pregabalin. Vesper asks, if things get worse, are there other meds you could add to help my anxiety? As you're preparing your response, Dylan, who has been gulping down a bottle of cola throughout the appointment, belches loudly. As the sound reverberates off the walls, Vesper turns bright red and stares at the floor. What are the adjunctive medications used in social anxiety disorder? They're bupropion, aripiprazole, risperidone, and paroxetine. Alright, now to summarize. So our mnemonic now reads GOPS, PARCA, RIO, BARP. For generalized anxiety disorder, we have pregabalin. For OCD, we have aripiprazole and risperidone. For panic disorder, we have clonazepam and alprazolam. For PTSD, we have risperidone, ezopiclone, and olanzapine. And for social anxiety disorder, we have bupropion, aripiprazole, risperidone, and paroxetine. Alright, now on to bipolar disorder type 1. Okay, so first we'll talk about acute agitation. So you were a third-year medical student at your psychiatry rotation, and tonight is your first call shift. Thankfully, you're only on until 11 because you have teaching tomorrow. You were sitting in the side room with your senior resident chatting and answering a few emails. The senior resident yawns and stretches his arms wide into the air. Looking down at your watch, you see that it's 10 o'clock. Rubbing the back of his head, the senior resident comments that the night has been oddly quiet. As if on cue, commotion erupts in the hallway just beyond the office door. Curious, the senior resident pries the door open just far enough to make out 3 security officers assisting a diaphoretic, half-naked man with bright pink hair into one of the ICR rooms. The resident sighs and closes the door. Moments later, the resident is on the phone with his attending. Upon hanging up, you learn the man is well known to inpatient psychiatry. His name is Lance, and he struggles with type 1. Since his arrival, Lance has been banging the ICR door and screaming and yelling loudly. He will not settle down and is causing damage to himself as well as everything around him. What are the first-line treatment options for acute agitation in bipolar 1? They are aripiprazole, lorazepam, loxapine, and olanzapine. And what are the second-line options for acute agitation in type 1? They are asenapine, haloperidol, risperidone, and ziprasidone. Okay, so now we'll talk about acute mania. So eventually Lance settles and you make your way home. Next morning you're working with Dr. W on the inpatient unit when a familiar name appears on your patient list, Lance Anam. You learn that he was transferred from second floor after he was caught having sort of consensual but ill-advised sexual intercourse with another patient on the unit, who turned out to be his ex-girlfriend. Aside from managing agitation, Lance has not been prescribed any other medications. He's still acutely manic. Dr. W asks you to see him and decide what first-line option you would like to start. Which first-line treatment for acute mania do you recommend? They are lithium quetiapine, valproic acid, asenapine, paliperidone, greater than 6 mg, risperidone, and cariprazine. As well, there are first-line combinations. These are quetiapine, aripiprazole, risperidone, and asenapine, and they are paired with either lithium or valproic acid. Right, on to maintenance. So 2 weeks pass by and Lance A&M begins to stabilize. Later, the social work has arranged a team meeting with Lance's outpatient supports to assist with discharge planning in 2 days' time. Unfortunately, Dr. W will be unable to attend the meeting and has asked you to avail yourself to serve as her representative. Somewhat nervous but wanting to appear keen, you hesitantly agree. Preparing for the meeting, you sit down with a social worker who tells you there will be a piece of cake as long as you remember all the first-line recommendations for maintenance of bipolar type 1. What are they again? And so they are asenapine, lithium, quetiapine, valproic acid, aripiprazole, and lamotrigine. And now on to bipolar type 1 depression. Months go by, and with it, what remains of medical school. Having come to your senses, you applied for and were accepted to the psychiatry residency program of your dreams at the University of Saskatchewan. It is your first college trip with the letters MD behind your name, and you're eager to prove yourself. Well, look who it is. Lance A&M, back in the emergency department. In sharp contrast to the loud, animated, and disinhibited man you met in clerkship, you find a quiet, despondent, and overtly depressed and tearful individual with a suitcase at his feet and a bandage wrapped tightly around his right forearm. What are the first-line recommendations for depression in the context of BP81? So they are quetiapine, lithium, lamotrigine, and lurasidone. And now for a summary of this part. So for agitation, we had LOIs or COE. This stands for aripiprazole, lorazepam, loxapine, olanzapine, all of which are IM with the exception of loxapine, which is intranasal. And we have asenapine, haloperidol, risperidone, and ziprasidone. These are sublingual, intramuscular, oral dissolving tablet, and intramuscular, respectively. Then we have acute mania treatments. We have our independent medications and our combos. So we have lithium, quetiapine, valproic acid, asenapine, haloperidol greater than 6 milligrams, risperidone, and cariprazine. For combos, we have quetiapine, asenapine, risperidone, and aripiprazole, with the addition of lithium or valproic acid. And then on to maintenance, we have LQ-Val, which stands for asenapine, lithium, quetiapine, valproic acid, aripiprazole, and lamotrigine. And then for depression, we have quetiapine, lithium, lamotrigine, and lurasidone. And now on to type 2. Okay, so first we'll talk about depression. So you're a PGY1 participating in an elective at the Student Wellness Center with Dr. Holt. Today you've been asked to interview Miranda, a 24-year-old patient that Dr. Quinn diagnosed with ADHD in childhood. On assessment, Miranda appears tearful and affirms almost all of your MCG-CAPS questions. Typically a high-functioning PhD student, she reports that her productivity has steeply declined. Now plagued by low motivation, she expresses the fear that she'll never get better. I just don't understand it, she cries, head in hands. Things were going so well. Just the week before I was getting so much work done and had so much energy. I was so confident, and even though I was working around the clock and sleeping only a few hours per night, I never felt tired. I felt so good. Review of systems is significant for previous episodes of depression as well as what you think were hypomanic episodes. What are the first-line treatment options for BPD2 depression? There's only one medication and it's quetiapine. And now on to maintenance. So your time at Student Wellness Center flies by, and now is your last day of the rotation before moving on to internal medicine. Miranda is back in the clinic today and by all appearances returned to euthymia. Although somewhat surprised by the quick turnaround in mood, you were happy to see her back in fighting form. She thanks you and Dr. Holt for the quetiapine prescription and for clarifying her diagnosis of type 2. Her mood has been much more stable lately, and she is adamant to be kept that way. What are the first-line options for maintenance treatment of BP82? And there are 3 of them. It's quetiapine, lithium, and lamotrigine. Okay, so in summary of this part, for depression we have just one medication, that's quetiapine, and for maintenance we have quetiapine, lithium, and lamotrigine. Okay, on to antidepressant considerations. What are the 6 antidepressant medications with greater efficacy based on meta-analyses mentioned in the CANMAG guidelines? So they are escitalopram, mirtazapine, sertraline, venlafaxine, agomelatine, and citalopram. So now on to cytochrome P450 enzyme considerations. First we'll talk about major substrate, CYP1A2, CYP2B6, CYP2C19, CYP2D6, CYP3A4, and for good measure we'll also talk about polyglycoprotein ABCB1. Okay, so first we'll talk about CYP1A2, and the vignette reads, if you're a cleaner working in a well-known hotel franchise, your manager has asked you to attend to room 1A2 as the family of 7 who is staying there this week has just checked out. You gather your cleaning supplies and make your way down the hall to the room. It's a complete disaster. Sheets everywhere, food wrappers and garbage littered all over the floor. You hold your nose in a feeble attempt to protect yourself from an overwhelmingly noxious smell. A pill bottle has been spilled all over the floor. You bend down to examine them. The pill bottle reads, Dabigatran. A DOAC. You vacuum the rest of them up, shaking your head as you reflect on the chaos before you. The mnemonic is VAC-DOAC, and it stands for vilazodone, agomelatine, clomipramine, duloxetine, olanzapine, acenapine, and clozapine. For CYP2B6, there is just one medication, and that's bupropion. CYP2B6 has a B in it, as does bupropion. On to CYP2C19. You've really done it this time. It's the last joke you've made at your co-resident's expense, the straw that broke the camel's back, and now you've been sent to the program director's office for an emergency disciplinary meeting. Sweating and nervous, you review the email notifying you of the meeting. Dear Dr. Mean Resident, we have recently reviewed your conduct and find you in violation of Article 2C19 of the Resident Code of Conduct. As a result of your obvious moral failing, you will need to see me to discuss disciplinary action. Your meeting goes about as well as expected. Your punishment, clean out the resident lounge fridge and take in the recycling. The mnemonic is 2CME, or 2CMe, and it stands for clomipramine, citalopram, moclobamide, and escitalopram. On to CYP2D6. You've done it. You've convocated from your Bachelor of Commerce degree and are on your way to dominate the business world. First step, a job interview at the firms of your dreams with Vice President J.J. Jerkson, a hard-ass Canadian business leader with a penchant for grilling new grads. How hard can it be? The mnemonic is VP, hard, can, biz, and it stands for vortioxetine, paroxetine, haloperidol, aripiprazole, risperidone, duloxetine, clomipramine, amitriptyline, nortriptyline, brexpiprazole, and ziprasidone. And on to 3A4. So you're visiting Grandpa Murray on a sunny Sunday afternoon. Grandpa Murray is doing well, and you know he loves nothing more than hanging out with you and watching football. On the screen, the ball is snapped back. Finding open players, Johnson makes a run for it. The once calm, long-term care is disrupted by Grandpa Murray's shouts of encouragement as the QB chaser flattens Johnson just before the goal line. The mnemonic is CALM, LTC, QB chaser, and it stands for clonazepam, alprazolam, levomilnazepam, mirtazapine, lorazepam, trazodone, citalopram, quetiapine, brexpiprazole, clomipramine, haloperidol, aripiprazole, sertraline, isoprene, and risperidone. There's just one medication for polyglycoprotein ABCB1, and it's risperidone. And now for a summary of all of our medications from this part. So for CYP1A2, we have vilazodone, agomelatine, clomipramine, duloxetine, olanzapine, acenapine, and clozapine. For CYP2B6, we just have bupropion. For CYP2C19, we have citalopram, clomipramine, moclobamide, and escitalopram. For 2D6, we have vortioxetine, paroxetine, haloperidol, aripiprazole, risperidone, duloxetine, clomipramine, amitriptyline, nortriptyline, brexpiprazole, and ziprasidone. For 3A4, we have clonazepam, alprazolam, levomilnazepam, mirtazapine, lorazepam, trazodone, citalopram, quetiapine, brexpiprazole, clomipramine, haloperidol, aripiprazole, sertraline, isoprene, and risperidone. And then we also have one more medication for polyglycoprotein ABCB1, and that's risperidone. Okay, so for inhibitors, we have a poem first, and it reads, funny people feel better, my mocking feels funny, dad's weak, funny mocking caves, laugh funny. Each of these words corresponds to a different medication, which you'll see as we go through these slides. So for strong inhibitors, we have the saying, funny people feel better, The word funny is a 1A2 inhibitor. People feel better are 2D6. We translate this 1A2, we have fluvoxamine. For 2D6, we have paroxetine, fluoxetine, and bupropion. For moderate inhibitors, we have my mocking feels funny, dad's weak. So 2C19, mocking feels funny. We replace these with drug names. We have moclobemide, fluoxetine, and fluvoxamine, and DAD stands for duloxetine, which is 2D6. For weak inhibitors, we have funny, mocking, caves, laugh funny. Funny, mocking, caves corresponds to 2D6 and stands for fluvoxamine, moclobemide, citalopram, acenapine, venlafaxine, escitalopram, and sertraline. And for 3A4, we have laugh funny, which corresponds to urazodone, alprazolam, and fluvoxamine. And now to revisit our poem. This is to make it more explicit. And so we have coverage for our 1A2 and 2D6 strong inhibitors. We have 2C19 and 2D6 moderate inhibitors, 2D6 and 3A4 weak inhibitors. And so that's everything that we've gone through. And just to go through these things one last time, for anxiety and related disorders, we have Dave's PowerPoint, which is duloxetine, agomelatine, venlafaxine, escitalopram, sertraline, pregabalin, paroxetine, paroxetine CR. For OCD, we have escitalopram, fluoxetine, fluvoxamine, sertraline, and paroxetine. For panic disorder, we have venlafaxine, escitalopram, sertraline, citalopram, fluoxetine, fluvoxamine, paroxetine, paroxetine CR. For social anxiety disorder, we have venlafaxine, escitalopram, sertraline, pregabalin, fluvoxamine, and fluvoxamine CR, and paroxetine CR. For PTSD, we have paroxetine, fluoxetine, sertraline, and venlafaxine. For BPAD agitation, we have aloe-IS or a COE, which is aripiprazole, lorazepam, loxapine, olanzapine, all of which are IM, with the exception of loxapine, which is INH. And then we have, for second line, acenapine, haloperidol, risperidone, and ziprasidone, which are sublingual, intramuscular, oral-dissolving tablet, and intramuscular, respectively. And then for acute mania, we have LQ-VAP-RC for our single medications and Cara Plus for our combinations. So we have lithium, quetiapine, valproic acid, acenapine, paliperidone greater than 6 milligrams, risperidone, cariprazine. And then for combinations, quetiapine, acenapine, risperidone, aripiprazole, plus the addition of lithium or valproic acid. For bipolar depression, we have quetiapine, lithium, lamotrigine, and lorazepam. For maintenance, we have acenapine, lamotrigine, quetiapine, valproic acid, aripiprazole, and lamotrigine. For type 2 depression, we have quetiapine, and for type 2 maintenance, we have quetiapine, lithium, and lamotrigine. The 6 medications in major depressive disorder with greater efficacy based on meta-analyses are escitalopram, mirtazapine, sertraline, venlafaxine, agomelatine, and citalopram. 1A2 major substrate are vilazodone, agomelatine, clomipramine, duloxetine, olanzapine, acenapine, and clozapine. For 2B6, we have bupropion, 2C19, escitalopram, clomipramine, moclobemide, and escitalopram. For 2D6, we have vortioxetine, paroxetine, haloperidol, aripiprazole, risperidone, duloxetine, clomipramine, amitriptyline, nortriptyline, brexpiprazole, and ziprasidone. For 3A4, we have clonazepam, alprazolam, levomilnacipran, mirtazapine, lorazepam, trazodone, citalopram, clomipramine, haloperidol, aripiprazole, sertraline, ezopiclone, and risperidone. Then we have the mnemonic, funny people feel better, my mocking feels funny, dad's weak, funny mocking caves, laugh funny, to remember the inhibitors.